Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about diabetes mellitus. When I left off last week, I completed a show on diabetic ketoacidosis, which is one of the two major acute problems in diabetes when dealing with diabetes mellitus. In this segment, I'm going to talk about the second problem, namely the so-called non-ketotic hyperglycemic hyperosmolar syndrome. What that means is that the body is not using fat as a source of energy, so therefore that's where the word non-ketotic comes from. When one tests the urine, there'll be no ketone body in there. However, the blood sugar is super high, anywhere from 600 up to 1500. I have seen blood sugar in excess of 2000 over the years in this particular syndrome. It is a very deadly syndrome. And what can cause it to happen is because the patient failed to take medication for diabetes, be it insulin or oral agent to treat diabetes, or the patient may have pneumonia, the patient may have a urinary tract infection, the patient may have had a heart attack or a stroke, anything along the line that can cause the patient to have stress. Well, what does stress has to do with it? Well, stress has a lot to do with it. Because once you have stress, your level of adrenaline is very high. Your level of cortisol is very high. Those hormones are anti-insulin. Once the level in the bloodstreams is elevated, insulin becomes ineffective, cannot do anything to bring the sugar down. It's somewhat similar to what occurred in diabetic ketoacidosis, somewhat similar. Stress always plays a major role in that. And unfortunately, sometimes the patients stop taking the medication because they run out of insulin, they don't have the money to pay for it, or they're so tied up in so many other activities. Sometimes they abuse alcohol, they become drunk, they forget that they're supposed to take the medication, etc. And the list, of course, is quite long. And what are the symptoms? The list, of course, of symptoms are quite long. Number one has excessive thirst, dry mouth, tongue is very dry, increased urination. Every 15 minutes they're running into the bathroom to urinate. Warm, dry skin, fever, drowsiness, confusion, hallucination, vision loss, convulsion, and of course, coma. And then the sugar becomes so high, they're urinating so much, it becomes markedly dehydrated, extremely dehydrated. That's where the hyperosmolar syndrome part of it comes in. Severely dehydrated, and sometimes the patients are not aware because they start becoming confused. And once they come in contact with the healthcare professional, they have to rush them to the emergency room. You have to understand, between 25 and 50% of people with this syndrome go into coma in this country. The death rate is very high. The number of people get hospitalized for this syndrome is also very high. So once the healthcare professionals who are involved in caring for this patient realize what's going on, then they must quickly intervene by finishing the examination quickly, get some of this finding that I just mentioned to you. If the patient can talk, or the patient family, or whoever is with the patient can explain to them what's going on, then they can quickly, the finger stick, the sugar is so high, it cannot be read on that little machine because it is that high. Then they must quickly realize what's going on, get an IV started, get the EKG done, the chest X-ray out of the way, the blood count, the complete metabolic profile, and then quickly the patient they do a blood gas, etc. Then you have to start IV fluid. In this case, half normal saline is better than normal saline because the patient is so dehydrated. The sodium is probably going to be very high. Electrolytes are completely out of whack. You have to give the patient an immediate dose of 500 cc's of this half normal saline, then start an IV at about 200 cc's per hour, thereabout. And then quickly the patient must be given intravenous insulin. In this setting, you get the patient 20 units of regular insulin quickly, now that you get a blood test out of the way. And then put the patient on insulin pump. The urine is going to be packed with sugar, 4+. You check the urine to see if there's excess white cells in there, looking for urine infection. Whilst you send the urine culture, that's going to take 72 hours to come in. But if you see a lot of bacteria and your nitrate is positive, that's a urine infection. Then of course you will quickly address that by giving the appropriate broad spectrum antibiotic. You send a couple of sets of blood cultures. If the patient has fever, then you're concerned about sepsis. Once you get your blood culture out, you get your chest x-ray, because urine culture out of the way, then you must quickly start giving the patient who's febrile medication to bring the fever down. If the patient is confused, you have to find a way to bring the fever down. And then you have to start giving them broad spectrum antibiotics that covers for gram-negative, gram-positive, and anaerobe. You must know which antibiotic that you're going to choose empirically. You absolutely cannot miss. Cannot miss this infection. And you cannot wait for the result to come back. While you're doing all this, you check your EKG, you do a troponin to make sure the patient did not have a stroke. Get a CAT scan of the brain immediately to make sure the patient is not bleeding. CAT scan of the brain will not diagnose an ischemic stroke for you immediately. It will only diagnose old ischemic stroke or bleeding stroke. Then while this is going on, if your examination is consistent because of the confusion, the patient then you have to do an MRI, MRA quickly. Get all this stuff out of the way. All while all this is going on, your troponin is gone. Your EKG doesn't show, or does it show, doesn't it show an acute MI? And these doctors know how to read EKG very well. They can tell an acute infarction from an EKG. In the meantime, the patient is being treated. This patient must be quickly moved to the intensive care unit. This syndrome cannot be treated by inexperienced physician, or for that matter, nurse practitioners or PAs. They're good people, good professionals, but this is not in their league. This is a major league situation. You must have the best doctor that you can put your hands on at the bedside in charge of the care of this patient to save this patient. Okay, and you have to bring the blood sugar down very carefully while the patient is being properly hydrated. Patient is having blood sugar done every hour on the hour. Your basic metabolic profile is being sent to the lab every 6 hours or so. Patient is getting oxygen to try to save this patient's life. This is a patient who is dying. No if or but about it. Therefore, you want the patient in the best care. You want the absolute best clinician in charge. You may have other people helping you, but the head of the team got to be the best internist. Let me tell you something, the best internist, because internal medicine is the mother of the field of internists, and the field of medicine. You may call other people to help you out, yes, but the person in charge of the care, in charge of the team, has to be the best internal medicine clinician you can get your hands on. Because there are so many nuances. You have to be good at diabetes mellitus. You have to be good at managing electrolytes. You have to be good at, because this patient's kidney function is going to be affected. The B1 is going to be very high. The creatinine is going to be very high. Okay, you can get it in an ultrasound if you want to, but that's not the reason it's high, but you do it anyway to make sure there's no obstruction. The key is that the patient is so dehydrated. You have to know how to manage his kidney situation so as to prevent the patient's kidney from being permanently damaged. And you have got to know how to manage this stuff. You cannot just guess at it. The way medicine is these days, you cannot blame the people who are in the business of running hospitals because it is so expensive. And they're involved in a major battle every day fighting with insurance companies to pay for health care. I saved a patient's life a couple of months ago. No question about it. It was a dying patient. And the care was denied. And then I spent weeks trying to get a hold of the medical director of that particular insurance company. I finally get him on the line. He said, "Oh my God, Dr. Alcena, I am so sorry. I apologize. This was such a straightforward case. First of all, we want to thank you for saving the lives of our members, They said to me, "Coach, there is no doctor in the United States of America that we respect and trust more. We will never, there was no reason this should have been denied." But guess what? Are you ready for this? I haven't gotten paid yet. Okay? I sent the bill. This is 2.5 months ago. I did the bill myself. I have not seen a penny yet. The patient whose life that I saved is now back to work. I have not getting a single copper penny yet. After all this praise that I receive on the telephone from this very gracious medical director, I have not gotten paid yet. Okay? So suppose I was depending on this money to buy candy or gas for my car, the car will go without gas, okay? And I will go without candies. This is what's going on. This is how horrible the situation. And yet, God forbid, if I had done something that caused this patient death, I would spend the rest of my life paying the consequences of it. Okay? And yet, to this day, 2.5 months later, I have not gotten a penny yet. But the most important thing to me, it isn't the money, it's the fact that I saved this patient's life. Okay? All right? So therefore the hospital, they hire the people that can pay the least to provide the care because they're fighting to get paid. That doesn't make it right, but that doesn't make it wrong either. But suffice it to say, me as a physician and a patient advocate, it boils my belly knowing that this is going on. And I see it every single day. And I can't say, if I say anything, then you must be not only punished, but you must be destroyed as a professional person and as a person. Personal attack, because you're too loud. You know too much. Not that they appreciate the fact that you say, and what's funny about it, what was so interesting about this, I'm reading the email of this particular hospital. I got a thank you from the hospital as well, because they put it on the website as an example on how things are supposed to be done. You can't make this up. And yet, I have not gotten one. The hospital got paid, for sure. I have not gotten one single penny. Not only that, I was praised by the medical director. I was praised by the hospital for putting this on the website so everybody on the staff can read it. Thank you, Dr. Alcena, for doing such a great job. That's the term they use. So you got to understand, that doesn't deter me, because I'm not in this business for the money part of it. I'm in this business because my job is to do the best I can to help a fellow human being. If I agree, once I agree to do it, you could bet I will fight for you nonstop. So this particular syndrome then is deadly. It is absolutely deadly. You must recognize this non-ketotic hyperglycemic hyperosmolar syndrome quickly and manage it appropriately. There are multiple aspects to it. You must be good at all of it. You can't get 15 doctors telling them stepping on each other. You have to be in charge so that you could save this patient's life. You don't have much time because this patient cannot use glucose. You cannot use oxygen without glucose. Not only that, the patient is so dehydrated, he's confused. The confusion, you cannot Let me repeat that. You need glucose in order for us human beings to use oxygen. So if you're not able to use glucose, you cannot use oxygen. Therefore, if the brain is starving from oxygen, there's going to be permanent damage to the brain. So now that you got all your results back, your patient is starting to wake up. Now you got to set up a treatment plan for this patient. Now all of a sudden, you have a patient who couldn't use glucose. The glucose was so high. Now that you bring the glucose down, now you're going to have to, patient is not able to eat yet. You can't make this up. Patient is still so sick, cannot eat yet. And guess what you're going to do once this is all under control? You're going to change the IV fluid. Guess what you're going to put in the IV fluid? Are you ready for this? Glucose. That's right. Because now that you have control over the situation, you're in control. You need glucose so that the insulin can push the glucose into the cell to keep the patient in an anabolic state. When you're treating a very sick patient, you want that patient to be in an anabolic state. There's nothing that can put a patient best in an anabolic state rather than glucose. Even if they're giving you hyperalimentation intravenously, which we do sometimes, one of the major component of that hyperalimentation treatment is glucose. That's correct. But have no fear, because you're in control of the electrolytes. That's right, because you're giving the patient insulin. If you're talking about giving patient insulin, you got to watch the potassium very carefully, because insulin can cause low potassium. And once the potassium is low, a whole lot of other terrible things can happen to the patient, including cardiac arrhythmias. So if you're not good at that stuff, you must. A study was done, must be more than 10 years ago now, out of Rhode Island, whereby they evaluated several hundred hospital ICU across the country. They evaluated several type of physicians across the country, including the new concept of having physicians who are only specializing in acute care medicine. After they evaluated several thousand hospitals, several 100,000 patients. Are you ready for this? The single doctor that got the highest grade that they recommended to be in charge of a patient care that acutely sick is an internist. That's what the study is, and it's published in the Annals of Internal Medicine. Okay, after evaluating all these doctors, all these different hospitals in an ICU setting, the patient that survived the most, the increased survival, was the patient where a general internist was the head of the team that's taking care of that patient. Well, you say, well, how come, Val? Well, how come is because general internal medicine is the mother of the field of medicine. When you're a generalist in internal medicine, there's nothing having to do with general internal medicine that you're not on top of. And most frequently, it is the nuances, the so-called nuances that others don't know about, is what saved the patient's life. The obvious thing, when I trained at Montefiore, we didn't have these acute care doctors. I was the people like me, that chief medical resident. We run the intensive care unit. We run the coronary care unit. We run the cardiac care unit, and we take turn. We run the ICU as well. That's exactly correct. We were the supervisors. That's what the role of a chief resident was, to make round with the younger physician, the intern, and the resident that's managing the patient, to tell them what to do. Now you have this thing. This is okay. I have nothing against it, but there are a whole lot of stuff these folks don't know. Sure, they can put a tube in quicker, faster than the internist can. Nothing wrong with that. but a whole bunch of stuff they just are not good at. They just don't know. In fact, they never learn this stuff. That doesn't mean it is a bad thing. It's just that they just don't know. You can't do that which you don't know and do it well. But if you're a general internist with years of experience, nothing misses you. You will take the chart. Give me this chart right now. I'm looking at it. I can find, just by glancing at it, I can find 6, 7 things that need to be done better. Mm-hmm. And that doesn't come cheap. It comes with years and years and years of experience. I wouldn't be sitting here talking to you the way I'm talking if I didn't know these things. I wouldn't have survived. As a man of color in the city of White Plains, what they put me through, I wouldn't have survived, but they can't touch me because they don't know a third of what I know. They just don't. This is not bragging, this is telling the truth. So therefore then, you need the best doctor at the bedside to be in charge of management of a patient with non-ketotic, hyperglycemic, hyperosmolar syndrome. Because if you don't, patient will not have kidney function left. Patient will not have brain function left. And the patient may have no eye function left because the eye will be affected as well. But if you understand how to manage the different paths, the do's and the don'ts, how to manage these electrolyte abnormalities, do all this other stuff well, and be in charge so that when you see something as you come every morning to review the chart, this needs to be adjusted. This needs to be adjusted. Then the patient cannot eat. And the patient is on antibiotic. So what are you going to do? Well, you're going to make sure if the patient is on antibiotic, I'm giving an example of what I'm talking about. Patient cannot eat, he's on antibiotic. If I were to ask you, what you're going to do to prevent this patient from bleeding, because he or she's going to bleed. You say, well, where's the bleeding going to come from? It's going to come because 10%, I'm just giving you an example of what knowledge I'm talking about. There are a few vitamins that we actually make in the human body. Vitamin K happens to be one of them. Well, the patient is not eating. He's on antibiotic. 10% of the vitamin K we need to prevent spontaneous bleeding is made by the action of bacteria in the colon. If the patient is eating, he or she can take vitamin K every day by mouth, part of the food, the veggies and whatever they're eating, but they're not eating. They're very sick. They have tools all over the place. So therefore, if you don't know that this patient is going to be deficiency in vitamin K, and then every day to give that patient 10 milligrams of intravenous vitamin K, because the half-life of vitamin K is about 6 hours. And the most common cause of bleeding in an intensive care unit or a CCU unit, repeat after me, is vitamin K deficiency. How about that? So if you don't know that, suddenly patients start bleeding, people are running all over the place, looking for all sorts of crazy stuff. It turns out that the most common cause of bleeding, other than surgical bleeding that occurs in a hospital setting, is vitamin K deficiency. Because you need that 10% to be in vitamin K balance, even when you are eating. So now you're not eating at all. And you can't make the 10% because every single antibiotic, no matter the type that you take, knocks out the billions of bacteria that are in the colon. They're all sensitive to any antibiotic, doesn't matter what it is. So therefore, if you take an antibiotic by mouth and you're at home, you're eating, you're okay. But if you're in a hospital, you're getting IV fluid, there are tubes all over the place, and you don't have a doctor who knows this stuff, how are you going to stop this patient from who already have so many problems? And now you're going to have bleeding on top of it, and everybody's running all over the place, find out what's the cause of the bleeding. I just told you it's going to be vitamin K deficiency. Even though the patient came in, the PTT, iron was perfectly normal, but guess what? You didn't know that this patient needs vitamin K because you will never learn that stuff. I didn't know this stuff when I went into training either, but I taught myself. How about that? Like I said to the other day, I went to one of the best medical schools in the country. No if or but about it. No bragging. Albert Einstein College of Medicine was the best medical school in the country, up among the top 25%. Montefiore Hospital was the top training program in the country. I went there. And yet, as I speak to you now, 90% of what I do every single day, what I write every single day, I taught myself. And yet I had some of the best teachers. But that's old medicine that's gone a long time ago. Okay? If I sit here keep doing the same stuff that I learned when I graduated medical school, 1973, when I trained at Monty, I finished 1978, give me a break. Nothing wrong with it. These are great places. But I had to be the best that I can be in order to even sit here talking to you. Because there's nothing under the sun they haven't done that you could do to a human being to eliminate me for no reason other than the color of my skin. For what? For no reason. I've done anything to anybody, but I know too much they must not only praise or complimented, but I must be destroyed. I must be discredited so that I can have a little thing next to my name. Yeah, he's great, but look at what he did. Okay? And I'm not unique. This is happening to women and minorities across the country. You have to understand this profession of medicine is a fantastic profession, but mirrors everything that's happening in the rest of society. Nothing is different. Okay? And the worst part of it, the most disgusting part of it, the people who are doing it are people who had to go somewhere into a 12 world country to buy a medical diploma. But because their skin color is different, they're now in charge. In charge of what? I have no idea. Okay? In any event, hyperosmolar coma is a terrible thing. Few people recover from it. Once you go into coma, you may or may not recover. Next week, I'm going to finish the series by talking to you about hypoglycemia. Until such time, this is Dr. Alcena saying so long and bye-bye.